I hope everybody is okay this morning. Don't forget water. I've got Advil if you need it. We also kicked things off this morning with a yummy networking breakfast sponsored by Salesforce. So I hope you got to enjoy that, as well as some connections. Are you guys ready for another day of inspiration and learning? We have a great day ahead of us. We'd like to begin with our land acknowledgement. So we gratefully acknowledge that we are on the traditional territories of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13, signed with Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississauga and Chippewa bands. We invite all attendees to reflect on the territories where you live as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. So I have the privilege of introducing this morning's Powerhouse Plenary panel, sponsored by Novartis, Embracing the Possibilities of Machine Learning and AI in Innovation. Please welcome to the stage Aloha McBride, Global Health Sector Leader from Ernst & Young, Rachel Dunscombe from Healthcare Lead AI Council in the UK Government, Andrea Marazzi, President of Novartis Canada, and Brad Wooters, Executive Vice President from Science and Research at the University Health Network, and the session moderator, Nadia Sapiro from Thoughtline Strategy, Inc. Thank you.
Hello and welcome. I'm very excited to facilitate this important conversation on the impact of AI and machine learning in healthcare. We've been hearing a lot of hype about the potential of AI. Today we're going to be hearing from our panelists about some real-world, concrete examples. We'll be going beyond the hype to understand how these technologies are making a tangible difference in the lives of clinicians and patients. Our panelists will help us to understand how governments and healthcare organizations can embrace AI and deliver more value while addressing some common misconceptions along the way. One very quick housekeeping note: we will be ending the session with a Q&A. There are mics throughout the room, and please feel free to also submit a question in the app. Now, let's do introductions and get started. My name is Nadia Sapiro. I'm president of Throughline Strategy, and we apply behavioral science and foresight to understand healthcare journeys, fuel innovation, and support behavior change. I will now be asking each of our panelists to introduce themselves. I'll also ask our panelists to share an example of a time they found surprise or delight at AI's capabilities. Now, heads up. I've been told that someone on the stage may be an advanced form of AGI, but I haven't been told who. Rachel, based on your unbelievable background, I think it might be you.
No, I'm just a recovering CIO.
Why don't you go ahead and introduce yourselves?
Thanks. So I'm Rachel Dunscombe. I formerly was CIO of the most digitally mature organization in the NHS. Now I am a policymaker, also an academic as well, and an advisor to Daedalus. But I'm very steeped in the AI space and regulation around AI in healthcare and other sectors.
Welcome.
Thank you.
Andrea.
So my name is Andrea Marazzi. Thank you for being here, inviting us. I'm president for Novartis Canada. I got so many questions on why a company like us is here today, and we aim to be really a health tech leader of the space because we do breakthrough science, but without technology and implementation of this breakthrough science, we will never be able to really deliver on the outcomes for patients. So great to be here.
Well, welcome. Aloha.
Hi, everyone. Good morning. Great to be here. I'm Aloha McBride. I lead global health for Ernst & Young, and Ernst & Young is an international professional services organization. We operate in over 150 different countries, and in my role, I have the opportunity to really help both the private sector and the public sector health entities to help them solve their most difficult challenges. My background is in healthcare strategy and transformation, and I have a huge passion for technology and how it can help our populations.
Welcome.
Hi, good morning, everyone. I'm Brad Waters. I'm the Executive Vice President of Science and Research at University Health Network in Toronto. UHN is Canada's largest academic medical center with almost 5,000 scientists, and technology, data science, and its application in medicine is a big part of our strategy, and is currently already being used to implement new approaches to therapy at our hospitals at Princess Margaret, Toronto General, Toronto Western, Toronto Rehab in Toronto. And we're very fortunate to be located in Toronto, one of the birthplaces of artificial intelligence. There are terrific organizations that we collaborate with at the University of Toronto, with Vector, and with our partner hospitals around the city. And just really excited about the potential future and application that we're going to discuss a little bit this morning.
Thank you so much, Brad, and welcome to everyone. Thank you for joining us. So, I promised you we'd go beyond the hype. For our first question, what's a recent example of applied innovation in healthcare that already demonstrates the transformative power of AI and machine learning? Brad, let's start with you.
Yeah, sure. Well, I can give you a couple examples. Already, it was over a year ago, our doctors and clinicians and the teams that are working in our Princess Margaret Cancer Center to deliver radiation therapy to patients. And when doing so, it requires the creation of a treatment plan that has many degrees of freedom and options. So radiation can be delivered at many different angles for different periods of time, and the goal is to maximize the dose to the tumor while reducing the doses to sensitive normal tissues around that. And that's normally a very long and iterative process to decide on that plan. It often takes multiple days. And teams at the Princess Margaret, Drs. Tom Purdy and Chris McIntosh and Ali Berlin, developed a machine learning and AI approach to do that. It's something that AI is very good at segmentation and imaging. And they demonstrated that in 90% of cases, an AI algorithm in a few minutes could design that treatment plan to an acceptable standard by a radiation oncologist. And in 3/4 of the cases, 75%, that plan was better than a human-derived plan. And that's actually now being implemented in the delivery of care, reduces the time and the people involved that's necessary to do that by almost a factor of 3. The other example I would give is just a recent one. It was just published last week in the Lancet Digital Health in the area of transplantation. Drs. Mammoth Abat, using data from 65,000 patients that had long longitudinal measurements of clinical variables. Over 250 different clinical variables were used to predict the failure of patients receiving a liver transplant, 1-year and 5-year failures. And this is something that hasn't really improved in over 30 years. Those patients are susceptible to the development of infections, of developing cancer, and of graft failure. And it's not possible at the moment to predict who's going to fall into those categories. But there's enormous opportunity if we could, because they could be followed more closely, they could be screened, there could be interventions. And what she's demonstrated by learning on that data and then validating it on 4,000 of our own patients with that same level of data is an AI algorithm that can predict 1-year and 5-year outcome. And that's actually being implemented now on a dashboard in the medical record system so that the doctors and patients together can look at that risk and make decisions around moving forward.
Wow. Some unbelievable examples. Thank you. Andre, any examples you'd like to share?
Thank you, Nadia. Thank you, Brad. I think it's fascinating. So we have many examples, and I want to start saying that as an organization, we really rely on 2 principles. One is we're after big problems. That's what we are here for. And two is that we cannot do it by ourselves. So the partnership and collaboration with the ecosystem in a broad sense, it's absolutely critical. So we have a number of examples, but the one I want to share today with you, it's a collaboration and partnership with a company, Inodem Neuroscience. It's a Montreal-based company. Is AI power, eye tracking software technology. And what they do, they're able to really detect and process abnormal eye movement, that basically they're linked with a whole number of neurological conditions like MS. And MS, or multiple sclerosis, is a very serious disease. More than 100,000 patients in Canada. And by the way, Canada is a country where the prevalence of this disease is the highest in the world. So we have a lot of breakthrough medicine. We made huge advancement. Today you can rely as a patient on very effective and safe treatment, so with a very positive benefit-risk profile. However, if you look at how we diagnose the disease, how do we measure progression, we still rely on what we have discovered 50 years ago. I mean, they say even 100 years ago. So it's basically, I would say clinical assessment, subjective, or MRI, which is not a very accessible diagnostic tool, and it's very reactive. So we are able to detect the progression of disease sometime when it's too late, when brain damage occurs already. So how can we really be more proactive in a way we look at the disease? And this is actually what this technology does. So the eye movement biomarker has been studied in science, so it's very, very well connected with many neurological conditions. The problem is, how do you bring this to the clinical practice in a way that it's easy, can be experiential for patients and clinics, and that's what this company has been able to put. I mean, put this simple test, 5 minutes on an iPad or a tablet, can be performed, in a clinic or, a patient home. They are able to collect all this information and basically link this information with the progression of the disease. So we are now at the validation point of the tool. Hopefully soon, I think by Q1 next year, we will be able to bring this to clinics. And this is absolutely a breakthrough for patients. I mean, better clinical outcome, better efficiency for the system, and eventually what we want, which is the right treatment for the right patient at the right time. So as an organization, we do rely on this collaboration. So we believe that what we call strategic private-public partnership between academia, government, non-profit organization, and the ecosystem. I mean, everybody that is in this room can really advance how we deliver healthcare now and for the generation to come, in Canada. So we have many more other examples. I think in rheumatology, by the way, if you're curious, there is also something about oncology at our booth. So I really invite you to really, connect and create this connection and be, open to solve this big problem together.
Wonderful. Well, thank you so much. And, we actually had one question already on the app, which said, can you give us some concrete examples of AI in healthcare? And 5 minutes in, and we already have some fantastic examples. Yesterday, we heard from our keynote speaker on the idea that AI can deliver value by automation as well as augmentation. And personally, I get really excited about this idea, especially augmentation. How can we free up humans to do more of what they really love to do? And I'd love to actually see if there's a concrete example we can have of how augmentation is already improving clinical care. So maybe let's go to Aloha.
Yeah, certainly. So I think first off, I just put a statistic. We recently did a value-based care survey, and you all will be very interested to know that 56% of our Canadians surveyed really do believe that AI will be part of the diagnosis, the imaging, and the treatment plans within the next 10 years. So we see that adoption. From an augmentation standpoint, I'd point you to Intermountain Healthcare. They're doing some amazing work. One of the examples that they have in production today is with a tool from Medtronic called GI Genius. And I mean, even the name, right? It's fantastic. But what it is for is to identify precancerous polyps during colonoscopies. So this particular tool is based off of 13 million different images of polyps of various size and shapes. So really using that for the learning. So the clinician is alerted when this type of polyp is identified by the optical reader during the exam.
Wow.
So it's real time. And it's showing great progress, more than 14% additional polyps being identified than with a non-AI-based colonoscopy. So really impacting the population.
Thank you. That's a fantastic example. Rachel, I know you've got an amazing set of experiences from the NHS. Tell us more how augmentation is working there.
So I think augmentation works really well for me in two spaces. One is the back office, and I've got to say tools like RPA and automation really help with the likes of referrals, letters, the legacy systems we've got. But in the clinical space, which is the other space, you know, I've been working recently with Staffordshire and the mental health services there. We have got some amazing decision engines which are allowing patients to bypass going in to see a doctor and actually be referred directly to a service that they need. And that decision engine is self-learning, and it's suggesting back, you know, the sort of pathways people should use. Really interestingly, people said if you can refer online and, you know, go straight to a service, isn't that going to put more pressure on? But actually there are fewer people needing to see clinicians now. For instance, in the, you know, example of somebody that's been bereaved, the last thing they need to see is a doctor. They need to go to, you know, a bereavement service. So this is actually increasing throughput. It's allowing the clinicians to see the people they need to see, but it's allowing these third sector and other services to help people. And that automation and personalization of sort of the routing on your journey is really impactful for me. And it was actually rolled out, first of all, with children's services. And it's been amazing to see the waiting times come down for younger people to actually access services.
Thank you so much, and certainly for those of us living in Canada, where we have a shortage of primary care practitioners and there's a lot of bottlenecks. That sounds exciting and very promising. Hopefully folks in the audience are listening. This next question is for you, Andrea. How does quality data impact the effectiveness and capabilities of AI systems?
So thank you for the question, Nadia, because this is really, you know, a topic that I'm very passionate about, and you know, good quality data can, you know, simply revolutionize healthcare. And I think if you look at our industry or sector, this is where there have been, you know, good data management as, you know, really has been a catalyst of transformation, and this is where I think it's going to happen, or yet to come, but it's happening for healthcare. And it's about research, right? So we can discover, you know, better and new medicine faster. It's about you know, better patient care, so that we can really, as I said before, provide, you know, a good diagnostic, you know, a good risk stratification, the right patient, the right treatment for the right patient at the right time, so that we can really implement the technology and the innovation that we have. So I have one example in mind. I mean, it's about population health and how data can really, you know, change for chronic condition. After COVID, they have been, you know, at the forefront of the challenges that we have. So if you think about, you know, the data quality and the data that we have available, I mean, we can predict health issues. We can, you know, we can make better decisions. We can design new care pathways at a population level for these chronic conditions. So again, we can be more preventative. If there is, I was reading a you know, survey, and this is what patients they want the most. They want to be served, taken care of when it's not too late. And we have the toolbox. We have the toolbox in many different areas. So how can we design more preventative, you know, care pathways, so we can diagnose them early on, so before it's too late, before they're too sick, and we use all the tools that we have to, you know, to address this condition. I think, I mean, as an organization, as Novartis, we see, again, two, you know, different things, right, in terms of what is the benefit of data. One is on the research side, so we can, you know, by tapping into genomics bank, but also EMR and outcome data, we can, you know, fast track our development process and potentially bring this innovative treatment early on and solve some of these, you know, unmet medical need. But also when it comes to implementation, we have breakthrough therapies, but if we are not able to serve the patient in need, they're almost useless. And we have so many examples where we publish outstanding data, and so what, after many years, because the system is not ready to capture this innovation, we still have the majority of patients that they could be, getting this treatment and better life, better quality of life, longer life, they're still without it. So I think this is also where data can play a big role. And I think government and systems, they put a lot of effort in collecting this data. Now it's the time to, unleash the value. There is a great publication made by EY, and you can talk about it. And when you see the value of data for society, for the economy, for patients, we're talking almost about 10 billion pounds for UK, right, which is the most comprehensive system. But if you think about Canada, there was a lot of noise about the transfer between feds and provincial government. It's almost equally big, right? Mm-hmm. If we are able to tap into the value of that. So maybe you can share more about this survey, because I think was very insightful.
Sure. EY did a study within the NHS on what is the value of data. How can it be treated more like an intangible capital asset? And how should you look at it? So the study really looked at what's the nature of the data, what's the quality of the data, what's the maturity of the data, where is the data, how complete is the data. And we looked at it from a couple of different perspectives, from a big data perspective, from an AI perspective, and also from a personalized medicine perspective. And we thought about it in terms of how it would best benefit the NHS, pharma, medtech, health insurance. And when looking at it, you all are very experienced with these problems. You know that infrastructure, the ability to aggregate that data in a way wherein you're curating it, it's clean, it's standardized, and it can be used readily for what you were just talking about, Andrea, is the most powerful thing that you can imagine. And the NHS, like you said, has a huge data set. Rachel's intimately familiar with it, right? But what we have to understand is to get the utility from it, you have to drive the infrastructure to enable it.
Sometimes it's that data is actually not even being collected, too. There's an example in our cardiovascular group, Dr. Heather Ross, who studies heart failure and manages patients with heart failure. Most of the patients are in the community, and they're not receiving sort of daily care. And she's developed an app and wearable devices, phones, watches, and so on, that captures data which can be used to inform early intervention, just as you talked about. And is also using other kinds of data now and AI algorithms to help manage those patients, to predict and to be able to intervene early before a patient would otherwise land in the emergency room and come into the hospital. And this is an app called Medley. It's actually being implemented in several places in Ontario, including some First Nations, remote communities that are hard to access otherwise. And they've demonstrated they can reduce hospital admissions by 50% in patients that are managed remotely through this. But it does require the capture of new data that wouldn't otherwise normally be collected.
Well, thank you so much, Brad. And we know heart failure is such a tricky pathway to manage, especially in communities. So that's amazing to get those kind of results. I want to move on to talking about the specific challenges that lie ahead. While there's a lot of promise, there's also these challenges we have to tackle. And there are some hurdles that we need to address for us to really supercharge this investment. Brad, perhaps you're living here on the ground. Talk to us a little bit about some of the barriers you've experienced and how you've overcome them.
Yeah, well, certainly access to good data is probably the biggest limiting piece. And in healthcare, we're challenged not only by having the right kind of data and the right quality of data, but also the importance of protection and privacy around that data. And there's a lot of concern around this. We've recently entered into a partnership with a number of hospitals to help create a global platform for access to data. And this includes a partnership with Mayo in the United States, Mercy in the US in a different sort of geographical location, but also Albert Einstein in Sao Paulo and Sheba in Israel. And the goal of that is actually to create a global network that captures a much more diverse group of patients, and also a much more diverse group of the way that healthcare is provided. As we learn, of course, from our data, there are tremendous biases in there. The biases in the patients that we see, the biases in the way we deliver healthcare and our own structures and systems that are built around it. And so part of the motivation for this platform to be able to share and partner and access, tens of millions of patient records, in a global community like that, is to understand where those biases are, to create algorithms that account for them, and also be able to learn from the different ways that healthcare systems are implementing healthcare for that provision. I think one of the other big challenges yet that we're only starting to encounter, most of our challenges have been on the discover side. How do we discover it? How do we create opportunities? How do we create solutions? But there's going to be a huge challenge on how we implement this in an effective way. And this includes the regulatory side, but it also includes our own systems and so on. And I think, partnership can be a very powerful way to help us think about implementation as well, standardized approaches for that, for the validation, for continued monitoring and development of those systems. So we're going to face a lot of those. I think, in particular, our regulatory agencies, Health Canada, the FDA, there's no playbook yet on how these will be treated, and I think we're going to have to be working with those regulators to help, match the pace of what's happening in the scientific community on the discovery and the development side with its potential application and implementation.
Thank you so much, Brad. And maybe this is a good segue, Rachel. I'd love to, and I'm sure the audience as well, learn from what's happening in the UK, what's happening in Europe. What are the things we can learn from other regions, knowing how new it is? If you could speak to that.
Absolutely. So certainly in the UK, we're taking a multi-sector approach to AI. If you look at aviation, nuclear, other industries that life is dependent on, we're working together to get a regulatory framework for AI generally. And then within that, we are going to regulate AI within healthcare to make sure that we have the governance to go at safe scale and pace. And that involves our existing regulators. Now, the G7 were talking about this recently. They, they had a meeting last week, and there've been, a lot of press coverage around regulation. What I would say in Europe is they're being very sort of stringent about the regulation and going slower. In the UK, the Economist said that we're being lightweight, and I think the view might be that we're being lightweight and then adding, sort of sector-specific regulation underneath that. But what is really important here is that we do have that playbook, as Brad said, and that we get safe scale and pace, because the worst thing that we can do is not have that and allow flowers to bloom that are not safe. So really it's a tight balance, the balance of risk and opportunity, the ability to save lives and improve lives, versus risk within an industry or more generally. And so it's been really interesting for me. I've learned a lot from nuclear, I've learned a lot from aviation, and it's been fantastic to work with those experts on regulation.
Thank you so much. And I love that phrase, safe scale and pace, and that balance that we have to achieve. Andrea, the idea came up from Brad that partnerships might be really helpful to help us as we're navigating these challenges. Perhaps you can speak to how Novartis is achieving that.
Yeah, and I want to, before jumping on partnership, I want to build what you said, Brad and Rachel, is what are some of those barriers, right? And I think you touch on the system, on this, silos approach, and we have to really build the data infrastructure, on the risk, and I would, bring this nuance of, we tend to look at it just, with a very risk-adverse perspective. But for me, risk is also, not doing something. And the fact of not acting now, it's putting a lot of risk on our patient system. And so I think we have to really be mindful of, when we discuss about risk, that we have this, perspective of, yes, we can do something here, but if we don't do something there, we may really put our system and our patient, our population, our society even more at risk. And last, and I'm gonna get into the point, Nadia, it's leadership. I think this topic demands a lot of, leadership stance from everybody in this room, to really take this not just as one of the many priorities, but probably as the number one priority for the future. So I really invite everybody to take a stand, to take a leadership position, to demand leadership from the people you work with, because if we do that, then we can move into partnership opportunity like the one we have been able to forge with the Alberta government, right? So as Novartis, we've been working with Alberta Health, Alberta Services, the University Hospital Foundation to really develop a population health intervention for cardiovascular disease. And the goal is to really reduce, as you mentioned before, mortality, morbidity, hospitalization. And the foundation is really, leveraging data to a more proactive approach. So I'm not gonna steal the thunder. The team is gonna present this project later on. So if you have some time at 11, join Pod 5, I guess. It's a very exciting program for us. It's it's speaking about public-private partnership and what we can do all together.
Thank you. Now, this idea has come up around regulation, which is a tricky topic. Aloha, what should government be regulating? What should they be staying away from? Rachel brought this idea up of lightweight, right weight. What are your thoughts?
Well, I can tell you it's a topic around the globe. So we hear about what the US is doing, what Japan is doing, India is doing, the UK, Europe, Canada, of course. And what we hear is that everybody is very focused on providing guidelines and standards. A lot of concerns, common themes around trustworthiness, making sure that the biases are identified and cared for, that we're really looking at the fairness of the data. And something else that I think is coming up, and the FDA in the US just published something for public comment the other day, is around life cycle management. And Rachel and I have talked about this at length. And this is that concept that we're going to have predetermined change control plans for AI. And our governments, our constituents, our clinicians are really going to want to know how these are going to be maintained. How is AI going to be trained? How will it learn? How will it change? And how do you maintain the safety and effectiveness of it over time? And to this point, I think we talk a lot about the need for additional education. So when we think about how we train clinicians today, and you look at medical schools and nursing schools, I think we're a little behind the curve. We need to incorporate AI, basic AI training. I think we'll see it in higher ed and undergraduate courses, obviously, but clinicians especially need to be able to understand why it is that this particular algorithm is presenting them with this particular recommendation. And probably more importantly, they need to be able to explain it to their patients. So, Rachel, I know you have a lot of interest in this area. I don't know if there's anything else you want to add.
Absolutely. And in the UK, we've trained many hundreds of clinicians and senior leaders, postgraduate level, in data science. So I personally have led a program that trained 500 CIOs and clinicians, and got them very steeped in the world of AI and understanding the language, the framing of reference, understanding the sort of regulations, and also understanding life cycle management. Because traditionally we looked at an FDA or a CE marking for, AI. It's not about this. This is for life, and AI has to be monitored, and we need clinicians and senior leaders who can give it oversight. We also need systems to provide oversight. And I think we're pretty much on the front foot in the UK with that. We've got programs running at Imperial, Manchester, other universities for senior leaders. But that's had a real impact because it's allowed us to grow data science communities, and it's allowed us to have enough people who can actually have the conversation about how we're going to manage these things and to provide the oversight, in situ on the ground. And that's a real differentiator because skills is going to be the rate limiting factor according to our workforce planning in the UK. We've done workforce planning around this within Health Education England, and that, for me, as Aloha said, is one of the main things that we need to think about. How many people are confident and competent to take this leadership journey, as you said? And do you have that community who are ready? And I agree with Aloha, medical schools and nursing schools need to give you the 101 on this. It needs to be something that every clinician is learning now or doing as part of their CPD.
Thank you. This takes us nicely into the last part of our conversation, which is about common misconceptions around AI. And certainly, I think one of the most common misconceptions that we've all heard is that AI is going to come, it's going to take our jobs. And certainly, that worry doesn't, it lives also in healthcare. Will it take away the jobs of human healthcare practitioners? And I think, Rachel, you spoke to this idea of oversight being required. Brad, perhaps you could kind of build on this idea. How might AI augment the work of human healthcare practitioners so that they have fewer administrative burdens, can potentially serve more patients?
Yeah, I think that's the key word is augment, and it really, I think, has enormous potential to assist and augment and improve the care that we provide in many parts of the healthcare system. To give you a few examples, one which is being implemented now in patients undergoing surgery, laparoscopic surgery, Doctors Brudno and Mandani have developed an AI-based algorithm simply by watching thousands of these videos. So the laparoscopic surgery is done by video, it's all recorded, and so you can actually watch what the doctor has done. And based on training this algorithm on thousands and thousands of these videos, it's developed a tool to assist the surgeon in areas that they should not be cutting, dangerous areas that are never cut. And they can actually see this real time on the video screen, in a patient where there's a dangerous area that they need to stay away from. It can assist with training, it can assist with, prevention and quality and safety of those patients. I think we've all seen the explosion of the large language models. They've really only been around for a few months, but they've already implemented, or intersected many areas of society. And I think there's opportunity here on, some of the administrative side. We brought a lot of technology into the hospitals, into the healthcare system. It's undoubtedly improved quality and safety and enabled, a learning healthcare system and a capture of data. But it hasn't done much for the quality of life for our caregivers and patients. It actually takes them away from patients. It puts them in front of computers.
Yeah.
There's a lot of work and a lot of complaining that goes on because of the way we've introduced that technology. And I think what we're going to see now is the application of large language models and other kinds of tools to do that in the background. And we're seeing this happening already. Bo Wang at our institute has developed a tool to capture a patient-doctor interaction and generate a clinical note from it. And we've got physicians that are already using this to help them construct their clinical note. I know Microsoft and Epic are working on building this in, and this undoubtedly, this is a solved problem. In my respect, it's just a matter of an implementation side. And I think a lot of that kind of mundane, routine sort of work can be filled in through the creation of new solutions for that. And the worry about the loss of jobs or the replacement of jobs in healthcare, our challenge is there are not enough people to take care and of the growing healthcare need. We need solutions that are not going to be people-based and allow the people that are in the healthcare system to provide their talent and at an appropriate skill level and backfill the components of their work and the components of the work that's going on with new approaches. And undoubtedly, this is going to happen.
Thank you. I know, Rachel, you've spoken about this idea of pajama time. How does this idea of augmentation support kind of the reduction in pajama time?
Absolutely. So pajama time, going home and keying, your patient records on the sofa or whatever in your pajamas. We are putting our clinicians under huge amounts of stress and all of our healthcare workers. Certainly in the region I used to be CIO, the number of diagnostic images are going up by about 10% a year. And we've got a reduction in radiologists and other people coming into the service. We need to augment in order to take that pressure off and give people the ability to have a life outside of work as well. And for me, a lot of these solutions are really there to give time back to care as well, particularly, in nursing. So the augmentation here for me is really about tipping the balance that we have at the moment, which is becoming unsustainable for most healthcare systems globally. Almost the perfect storm, if you like. If we use this wisely, we can help readdress that balance and make sure that we're serving both our patients and our clinicians. But most of all, clinician burnout. I certainly know within the UK, many clinicians are feeling a lot less satisfied. How can we use this technology to give them more balance and take them back to the really interesting care that they should be giving with the complex patients?
It almost sounds like the reframe is, it's not a fear that AI could take jobs away, but if we don't have AI, will we have people who want to do these jobs?
Well, you know, looking at the figures that I was for diagnostics and radiology within the region I used to work, the question is, at what point do people start having breakdowns because of the pressure in the system? And for me, you know, we're making some great progress. You know, we're working with Cure.ai and other people around, you know, AI models to actually work out what needs to be reported where. But to be honest, we have a moral obligation to actually work out where we should be using this now to take pressure off clinicians.
Thank you. Well, with that, we're going to move to Q&A. So we do have mics throughout the room, so please feel free to make your way toward a mic. And I've also got some great questions from the audience through the app, which I'll go through. So for our first question, these technologies have been available for several years. What is getting in the way of adopting them in the healthcare sector in Canada? I don't know, Brad, if you'd like to tackle that one.
Yeah, well, I think, you know, we've seen they have become available for, you know, or have at least been talked about for several years, but the pace at which that change is happening, and we all sort of feel that, you know, I think is far faster than anyone imagined. Even the biggest zealots of AI, you know, I don't think imagined how fast this would move forward. Our healthcare system, you know, ultimately is going to be, you know, a crucial partner in understanding where it can be implemented and how and what the appropriate nature of that is. And it goes back to this discussion around the importance of partnerships. I think there are many global companies that are working on AI solutions and are pushing the field forward, but the limiting factor, I think, in this creating impact is the partnership with the healthcare system, with healthcare providers, with patients, and understanding, you know, where it's going to augment care, where it's going to shift care to earlier intervention, and where it's going to allow us to, you know, provide more precise treatments or more tailored treatments to individuals. So I think that to me is sort of the big challenge, and I think everyone's going to feel like this is going too slow. I think you think it's going too slow now. Wait a year or 2 years. People are going to be, you know, wondering why this isn't going faster than it is. I think we all need to really, you know, think about how to help, how to assist, how to partner, and you know, how to help realize the potential of what's coming.
Thank you, Brad. And we have a question in the center.
Hi. Stephen Grover. I'm a physician. I work at McGill University. I really enjoyed listening to all of your...
Sorry, I think it's a bit tricky to hear you. If you can go a little closer.
Is that a little bit better? Okay. Hi, I'm Stephen Grover. I'm a physician at McGill University. I enjoyed all of your comments. I agree with you. I think digital health and AI has a tremendous future, but I don't think we can overlook what we're facing at the moment as we come out of the pandemic and we're looking at this baby boomer tsunami that's completely jamming up our hospitals and emergency rooms. Where I work in Montreal...
I'm so sorry. We're having a really hard time hearing you. Can you just adjust the mic? Maybe let's try that one more time.
Okay. Well, I'm short. Maybe this works better?
That does, actually. Thank you so much for your patience.
All right. I agree with all the things you're saying about AI and digital health, but I think it's really important to remember that we've got a healthcare crisis at the moment. We have insufficient numbers of health professionals, an aging population that's increasing its demand for healthcare, and AI and digital health is not going to solve these problems in the short term. In fact, if AI and digital health work properly, it's going to increase the demand for healthcare because we're going to detect more undetected disease, and we're going to help improve adherence of patients that's already terribly suboptimal. So I think one of the things all of us in this room need to be asking ourselves is, how are we going to integrate ourselves into current work habits with healthcare professionals? I can tell you from my own experience, 20 years ago, we published papers showing that you could evaluate someone's cardiovascular age and improve the likelihood that they would reduce their cholesterol or blood pressure. But one of the things I learned over the last 20 years is physicians wouldn't use this. It took time out of their day. And patients, even when they were engaged with it, they wouldn't change their lifestyle habits without a professional supporting them. So my suggestion to all of you and the people in the room is ask yourself, how am I going to incorporate this into busy healthcare professionals' routine? How am I going to engage patients to do this? And if you look at the things that we do really well in digital health already, it's build community. In other words, improve communication between individuals. It's tracking, which allows people to see if they're meeting their own objectives. And theoretically, it's going to be early diagnosis and adherence. But I like all the stuff you guys said.
Thank you so much. And I'm going to just pick on an early part of kind of what you were talking about, which is this challenge that even if AI is coming into the healthcare landscape, there's still potentially going to be this shortage of healthcare practitioners. So how do we solve for that part? I think that's a really interesting challenge.
So if I could take that, we have got a shortage of healthcare practitioners, but I've done some real things with digital and AI to deal with that. I'll give you one example. Smart routing of nurses in communities so that they start their day near home, they finish near home, and they have the optimal route based on their skill set. That is now published. 23% more productivity in nursing with happier nurses because their expenses are keyed. And they were seeing patients that were at the top of their license. We can use this to actually optimize. And the example I gave earlier as well, I think, with the decision engine, again, taking pressure off the system. We do need to look at this, though, you're absolutely right, with a lens of compassion for all of our colleagues in healthcare systems, because the pressure is the thing we need to address. And I think that is an important point. We could go on hobby projects that we think are really interesting, or we could look at this and say, how do we get this to help the humans within the system? And I think we really need to do that. But having started early, if you like, in AI, data science teams and AI teams 5 years ago, there are several things that I have personally done with my teams to actually put in more productivity and deliver outstanding care. And so I'm slightly further ahead on the journey than some people, and I think there is a real hope that it can help with that capacity issue.
Thank you so much, Rachel. I'm going to ask one last question from the app. It says, what do you think about the pitfalls for AI to be fed with not representative data? Women, men, ethnicity, etc. And how do you protect your own environment from this happening?
Yeah, this is one of the, I think, most important topics to understand, especially when you're developing algorithms. We know that a lot of the clinical data sets do not include socio-demographic information, social determinants of health information, and without those elements, they're not complete. And those algorithms that are developed solely based on either a limited clinical data set or one that is skewed, be it for ethnicity, for gender, what have you, are not going to perform the way in which we expect them to when they're scaled. So I think conscious efforts around guidelines and standards for what appropriate data sets need to look like, inclusive of those social determinants of health information sets, is absolutely critical from a risk management standpoint.
Thank you so much, Aloha. As we close today, this has been a fantastic conversation, and I think, Andrea, there's something that you really said that struck me, which was the right patient, the right treatment, the right time. And listening to everyone on the panel here also talk about the role of healthcare practitioners in augmenting, if I could add, with the right care. And so, where we started off this panel, I promised we'd be talking about concrete examples, and hopefully everyone agrees this panel has delivered. But let's end, perhaps, with something a little bit more far in the future, perhaps a dream. So my question to close is, it's 2 years from now. I'd love to know the moonshot use case of AI that you'd be thrilled to present back here on this panel. Maybe, Andrea, we'll go to you first.
So I think, and by the way, I love the moonshot thinking. It's something that we made our own in our organization. I hope, in 2 years down the line, we can come back and say, I think we are making this effort on this chronic condition, particularly on cardiovascular disease. We have structured data platform and collaboration and data network that will allow us to redesign, a more proactive, care pathway for secondary prevention, so that we can improve, life, we can extend people's life, we can reduce hospitalization, we can be more personalized, we can meet where the patients are, we can deliver the care they need at the right time, and I think this is just tremendous value for everyone.
Thank you. Brad, what's your moonshot?
Well, I think the moonshot, and we're starting to see even some examples of it already, is the ability to diagnose healthcare issues, challenges, before a patient comes to see a doctor, or before they enter the healthcare system, so that they're being alerted to an issue, a problem, well in advance of it leading to a more serious problem and needing a different kind of interventional healthcare. I think it's possible, when we think about our aging society, the challenges that we all face in terms of the need for understanding and monitoring that, areas in cardiovascular disease, in early cancer detection, in preventing falls in elderly individuals, understanding all of those. I think there's opportunities for that to happen relatively quickly, and I think within a couple of years in many of those areas, there's a real chance of being able to have that kind of early intervention.
Thank you. And certainly that builds on this idea of falls prevention with our aging population, builds on one of our speakers from yesterday who talked about aging in place. And that would truly be amazing if we could support that. Aloha, what's your moonshot use case?
Maybe it's a baby moonshot, because I think we're there, we just need to do it. So there's been a lot of discussion around digital patient twins, and certainly with the platform that you all are embarking on, it's going to be very feasible to get utility out of those kinds of tools. I'm really interested in how we use that data to engage patients, to support clinicians in combating non-compliant patients, because I think we always leave the patients a little bit outside the equation. Without that engagement, we're not going to get behavior change, and without behavior change for many of our chronic diseases, we're not going to get true wellness. So my goal would be that we could develop personalized care pathways that are engaging for patients through the use of AI.
Wonderful. I think there's many in the audience who probably have the same dream as you. And Rachel, excited to have you last for your moonshot.
Absolutely, and I think my moonshot would definitely need us to have the governance and skills in place. So part of my moonshot would be to, to create the governance around this. But actually, if you look at ambulatory appointments, certainly in the UK, around about 30% of those are not actually needed. And yet there are people that do not get seen. Equally, we overtreat in some areas and undertreat in others. For me, it's about the precision of where our resources are put, to stop treating by rote and start treating by evidence, And that, for me, will take pressure off the system, because we will not be, seeing the people we don't need to see. It will be re-empowering the patients, and it will really make sure that every dollar spent is going to the right place. And I think AI has got the ability to give us the transparency to achieve that. And I'm hopeful in 2 years that we're doing the right thing with that dollar.
Wow. Well, 4 very inspiring moonshot use cases. I, for one, hope all of them come true. And I want to give a big thank you to our panelists for your time and making this such a fantastic panel. And a big thank you to our audience as well. Thank you very much.
Please welcome back to the stage our MC, Cassie Frazier.
Well, thank you, Nadia, Aloha, Rachel, Andrea, and Bradley for your important perspectives. That was an absolutely fascinating presentation, and I'm looking forward to hearing those moonshot events back at our conference in near time, not so far away, I'm sure. I next have the privilege of announcing 3 Digital Health Canada awards and their recipients. The Clinical Innovator of the Year Award recognizes clinical innovators who have shown outstanding leadership in Canada in advancing the use of digital health or virtual health in clinical practice, resulting in improved provider and patient experiences and outcomes. I'm happy to announce that the 2023 recipients are Dr. Mark Nazimi, Senior Manager, Clinical Solutions and Innovation Health at Thrive Health, Dr. Mohammed Al-Arakia, Managing Director, eHealth Center of Excellence, and Dr. Abigail Oritz, Staff Psychiatrist at the Center for Addiction and Mental Health at CAMH. The Emerging Leader of the Year recognizes emerging leaders who are in the first 7 years of their digital health or virtual health career and have clearly demonstrated leadership and achieved early success. I've met more than one of you here today. The 2023 recipients are Nancy Nagoyan, Project Manager, Outpatient Digital Experience Project at Providence Healthcare, Tarun Katapalli, Canadian Research Chair in Digital Health for Equity at Western University, and Mobeen Lalani, Account Executive at LockBio. Let's give a round of applause. The last award for this section is Startup Innovator of the Year, which recognizes startup innovators who have clearly demonstrated leadership and innovation and whose outstanding contribution has advanced digital health and virtual health in Canada. And the 2023 recipients are Ahad Bendali, Chief Digital Officer, founder of Get Ahead, powered by KeelMind, Jason Daly, CTO of Go Automate, and Oren Sabag from Chief Executive Officer at Avi Health. So congratulations to all. So I'd now like to invite everybody to head to the exhibit hall. We have a 30-minute networking break sponsored by Salesforce. Please take your time again to visit the booths where the exhibitors are ready to meet and chat with you. You'll find great information, and there's still some prizes to be won. So don't forget to collect your stamps for the Leadership Passport by checking into the booths. After our networking break, we'll head right into our first concurrent sessions at 10 a.m. So I'll see you on the trade show. Thank you.